Good morning, everyone. Instead of the usual routine evening time, today we are doing this lecture class on a Sunday morning. And my sincere apologies to all of you to make you wake up early in the morning on a Sunday. But because the ICRO PG teaching course was happening since Wednesday to Friday, so 2 consecutive classes had to be rescheduled. One was scheduled yesterday, and the next one today morning. And my sincere thanks to Dr. Ashutosh Mukherjee for his kind acceptance of this. First of all, this invitation, and then modification of the schedule. So, as part of our this month's lecture classes, which is going on based on gynecological malignancies, today morning we are going to have a beautiful class on management of vulval and vaginal cancer. And this class will be taken by Professor Dr. Ashutosh Mukherjee. Dr. Mukherjee is professor and head of in the Department of Radiation Oncology at Homi Bhabha Cancer Hospital, which is part of Tata Memorial Center, Varanasi. And in his previous affiliation, Dr. Mukherjee has worked as a faculty in JIPMAR and has also worked for few months at one of the prestigious private organization as well. Dr. Mukherjee is alumnus of UCMS Delhi, where he did his MBBS, followed by his training in radiation oncology at Safdarjung and BMMC Hospital. And let us all welcome Dr. Mukherjee. Thank you so much, sir, for accepting this invitation. And now, without wasting any further time, I'm requesting to please start your presentation.
Okay, so good morning, everyone. So today we'll be briefly touching upon simple but usually untouched topics, the cancers of the vulva and vagina. Most of us, when we read about gynae oncology as radiation oncologists, we focus on cervix and then endometrium, read a little about the uterus, a little about the ovary, and finally, if we have energy left, finish off the vulva and vagina in one quick read. The surgeons also spend most of their time with the endometrium. Later on, for them, the vulva. These two malignancies do remain untouched for quite a significant portion of our training periods. And one of the significant reasons for this is the lack of number of cases. So, coming on to the cancers of the vulva, these cancers predominantly involve the female external genitalia, and they're composed of the labia majora, the labia minora, the clitoris, and the Bartholin glands. So the labia majora are the most common site of vulvar cancer involvement and account for about half the cases. The minora accounts for between a sixth to a fifth of all the cases, so 15 to 20%. While there are multifocal lesions seen in nearly 5% of cases, and the clitoris and Bartholin glands are much more uncommon, hardly around less than 5%. So the reason for these cancers not being taught so frequently is that they constitute less than 5% of all malignancies of the female genital tract, and they are rare both worldwide and in our own country. Vulvar cancers present both by local extension and lymphovascular embolization. It is a disease of older women. Next slide, please. Yeah, it is a disease of older women with a typical delayed diagnosis, despite the vulva being an external organ. Median age of diagnosis is 68 years. Next slide. Since the last few decades, radical surgery, that is vulvectomy and inguinofemoral node dissection, has been the standard treatment. Lymph node involvement represents the most important prognostic factor, as a 5-year disease-specific survival in patients with no nodes, that is negative nodes, is more than 70% to even up to 93% in early stage, while in node positive disease it is less than 50%, ranging from 25 to 40%. Next. So, lymph node metastasis in these lesions have a set pattern, with lateralized lesions usually not crossing beyond the ipsilateral metastatic disease, while midline lesions can spread to both sides. Pelvic node dissection is routinely performed in most of these patients, and in recent years there has been a shift towards less morbid surgery, with more with an increasing role of chemoradiation initially in the adjuvant setting, now even as preoperative or definitive chemoradiation. So as you can see from this year analysis, the caseload has, as well as the death rate, has been more or less common through nearly 4 decades in the US. And if you see the number of cases, next slide. If you see the percentage of cases by stage, predominantly nearly 63 out of every 5 cases are localized to the primary site. This is according to the SEER database, with nearly 1/3 of the cases spreading to the regional lymph nodes. And how this affects survival is that the localized disease has a high survival rate, nearly 86%, whereas diseases going into the regional nodes, the survival falls to less than 60%. Next, please. So, vulvar cancer can be basically divided into 2 types. I'm talking of squamous cell carcinoma of the vulva. So, it can be basiloid or warty type or keratinizing. So, this basiloid or warty type is a multifocal disease. It is seen in younger patients. It is related to HPV infection. There is associated vulvar intraepithelial neoplasia, and there is an associated, there is a causal association with cigarette smoking. Keratinizing type is usually unifocal. It is seen in older women, and it is usually seen in areas adjacent to benign conditions such as lichen sclerosis or squamous hyperplasia. It is a more differentiated type of tumor, and VIN is not very common. So HPV is a major etiological factor for vulvar cancers occurring with a causal association in more than 40% cases. And HPV 16 is associated with nearly, of all the HPV associated vulvar cancers, 85% can be attributed to HPV 16. Prophylactic HPV vaccines thought to have the potential to decrease the incidence of invasive vulvar cancer, but data is still formative data. We don't have any definitive data. Now, in 2000, study of vulvovaginal disease divided the intraepithelial neoplasia in vulva in 2 types. One is the usual type, HPV related. One is differentiated type, not related. And the older classification of VIN 1, 2 or 3, which was based on the degree of histologic dysplasia, is being challenged now, because VIN 1 to 3 is no longer considered a biological spectrum or continuum. So they can be differential occurrences of the VINs. The differentiated VIN, that is the keratinizing type, has a higher risk of malignancy, and usually it is compared to the usual VIN, that is the HPV associated VIN, which is seen to occur in which malignancy is seen to occur in 26%, or that associated with lichen sclerosis, where it occurs in 28%, or in squamous hyperplasia in nearly 32%. This is data from Eva et al. And when the differentiated, that is a keratinizing type, the malignancy is seen in nearly 86%. So signs and symptoms are a lump or growth on the vulva, changes in the vulvar skin such as color changes or growth, itching in that area which is not does not go away, bleeding or tenderness. And what are the importance of occurrence of nodes? So broadly parietic, pelvic and inguinal nodes. So if the inguinal patient comes with enlarged inguinal nodes, the chances of finding a vulvar cancer is between 60 to 75%. If the groin nodes are not involved, then the chances of finding are less than a third. That's 25 to 35%. But if there is cancer and also if there is cancer in the inguinal nodes, the chances of cancer in the pelvic nodes is also between a quarter to one third, that is 28 to 30%. Next. So this diagram shows the basic pathways of lymphatic spread. The white colored nodes are the superficial group, includes the superficial femoral and superficial inguinal nodes. And the black colored nodes are the deep inguinal going on to the external and internal iliac nodes, and then the common iliac and the parietic nodes. So these are the main chain of nodes. Then next slide please. Important prognostic factors in vulvar cancers are the depth of tumor, the size of the tumor, the presence of nodes, and extensions beyond the vulva. These basically four are the prognostic factors, and all of these have some association with frequency of nodal involvement. So if the tumor depth is less than 1 millimeter, there is no less likelihood of any nodal involvement compared to if it is the depth of tumor goes up to 5 millimeter, then nearly a quarter of patients might have inguinal nodes even in early stage tumor. Similarly, tumor size less than 2 centimeter compared to more than 3 centimeter, the positivity varies from 20% to nearly 70%. And in cases of disease extending beyond vulva, more than half of these patients will have inguinal nodes. So coming to the staging, as we all know, stage 1, the HSCC stage 1, tumor basically confined to the vulva and centimeter or less in the greatest dimension. So it can be T1A, T1B. Okay, that depends on stromal invasion, more or less than 1 millimeter. Stage 2 is, or T2, sorry, not stage 2. T2 is again tumor confined to the vulva, more than 2 centimeter. T3 will be tumor of any size but contiguous spread to vagina, anus, or lower urethra. And T4 would include urethra, bladder, mucosa, rectal mucosa, or fixed pubic. Again, N1 and N2 would mean either unilateral or bilateral lymph node metastasis. And this can be again unilateral will be coming in stage 3, bilateral will come in stage 4A. And M1 breast metastasis would be stage 4B. So this is the combined staging. And if I would to dramatically exhibit it, on 2 centimeter or just adjacent involvement of the lower urethra. Stage 3, either nodes Hello, am I audible? I think my voice got just broken. Is it audible?
Yes, you are audible.
Okay, fine. I'll continue. So, I'll again start from stage 3 only. So, stage 3 is unilateral lymph nodes or disease extending to the next organ, either the anus, the rectal mucosa, or the bladder mucosa. Uh, no, the next slides, please. The pictorial slide. The next and the next one. Yeah. So I was there. So again, stage 3, unilateral nodes or disease involving the rectal mucosa, anus, or the upper urethra. So next slide. So if we were to therefore divide these diseases into local, regional, and distal, the incidence basically is around 60%, 30%, and 5%, with 5-year relative survival being 86% for local disease, 54% for regional disease, and 16% for distal disease. Stage-wise, the relative incidence of cases, again, as you can see, most of the cases, according to the SEER database, that is in the US, is in stage 0 and 1, that is in intraepithelial neoplasia and in stage 1, whereas just around 30%, one-third of the diseases come in stage 2 to 4. In developing countries, the situation is usually the opposite, where 2/3 of the diseases come in the later stages and 1/3 of the diseases come in early stages. So clinical survival then by FIGO stage and by nodal status, again, stage 1 expected 5-year survival 98%, stage 2 85%, stage you can see it is still regional disease. It has not gone beyond the unilateral nodes. So it is still 70% plus. And it is only in stage 4 we see a big drop to 30%, where disease has gone to the distal sites or bilateral nodes. Nodal status, groin negative, 5-year survival 90%, positive, a big drop to 50%. And in case of pelvic nodes positive, it is further down to 11%. So coming to the now treatment modalities, broadly the treatment modalities of choice are surgery and radiotherapy, with chemotherapy playing a supportive role to both sides. Now, basic surgical types are partial vulvectomy and radical vulvectomy, the diagram showing the relative area removed. So until the 1980s, the standard approach was radical surgery, including complete en bloc resection of the vulva and the regional nodes. In tumors only confined to the vulva or perineum, radical local excision with a margin of 1 centimeter has now generally replaced radical vulvectomy. Separate incision for the nodes has now replaced en bloc inguinal node dissection. So you have separate ipsilateral inguinal node dissection rather than en bloc bilateral dissection, and sometimes femoral node dissections are omitted. So the modern treatment modalities could be early stage radical local excision, where there is a likelihood of node advancement or stage 2 disease, modified radical excision with sentinel node biopsy. If sentinel node biopsy is positive, then go ahead with further radical node dissection. Advanced stages, chemoradiation, either in the adjuvant setting or as a neoadjuvant chemoradiation followed by definitive surgery or definitive chemoradiation. Sentinel node biopsies are, according to literature, nearly in a quarter of sentinel node biopsies, nodal metastases are seen. So you can save nodal dissections in 3/4 of patients with negative sentinel nodes. So upfront nodal dissection is now gradually giving way to sentinel node biopsy. So frequency of bilateral nodes is for midline disease 70%, Ambiguous lateral, that is near midline, is more than half, and totally lateralized position less than a quarter, just 22%. So what are the indicators of poor prognosis in a vulvar cancer? It would be advanced disease stage, presence of inguinofemoral nodal disease with or without pelvic nodes, two or more nodes, extracapsular disease, and large size of the nodal metastasis, more than 1 centimeter. Indications for chemoradiation are either anorectal, urethral, or bladder involvement, disease that is fixed to the bone, gross inguinal or femoral node involvement. Indications for post-op radiation include lymphovascular invasion, depth of disease involvement, stromal depth more than 5 millimeter, margins of surgery less than 8 millimeter or positive surgical margins, more than one node positive or extracapsular invasion in the nodal sample. Both these groups of indications have been based on studies by Heaps et al. On resection margins and GOG protocol 36 on tumor size and LVSI, and later for post-op GOG 37. Adjuvant, now coming to the specific treat or radiation groups, subgroups. What are the situations in which we give radiation in vulvar cancers? Adjuvant radiation or chemoradiation for the perineum. These indications, as given in the GOG studies, I have included in the previous slide for the post-op RT. So advanced lesions have been found to benefit more from further higher doses like 60 gray rather than 45 to 50 gray, with improvement in local control from 60% to 80%. Sometimes re-excision may not be sufficient even if negative poor prognostic factors are there, and you might have to give radiation if the surgeon is not sure about his or her margins. In cases of closed margins, along with other factors such as depth of invasion more than 5 mm or positive LBSI, adjuvant radiation should be considered. Minimum recommended dose is 45 to 50 gray, and as I've said, for advanced lesions, go up to 60 gray. Next, elective irradiation or chemoradiation for groin nodes. The standard treatment so far for vulvar cancer with negative nodes has been radical vulvectomy or wide local excision with bilateral inguinofemoral dissection. But as I said before, less than a quarter of these patients would actually have positive nodes on the pathology report. So 3/4 would have unnecessarily undergone a radical dissection, en bloc dissection, with its attendant morbidity. So there was a small study by University of Florida in patients of N0 to N1 nodes who underwent bilateral groin irradiation versus surgery. And in these patients, radiation was found to be superior with better survival, 15% 6 years versus 41%, with lower mortality rates of 29% versus 51%, and less chronic lymphedema at 16% versus 22%. So, prophylactic or neoadjuvant irradiation to the groin can replace bilateral en bloc dissection along with a primary vulvectomy or a wide local excision. And then next slide. Yeah, same slide. GOG 37 was the study which created the indications for adjuvant radiotherapy. And in GOG 88, radical vulvectomy itself, along with elective node dissection, compared with standard superficial and deep inguinal dissection. However, this trial was stopped because of a high rate of nodal failure and death in the radiotherapy arm. So it compared elective nodal radiotherapy plus radical vulvectomy. The problem was that in this trial, the nodes were irradiated by a single anterior field prescribed to a depth of 3 centimeter, while pelvic CT imaging showed that the nodes lie anyway beyond 4 centimeter to even up to 6 centimeter. So GOG 37 previously had actually used APPA fields, So in GOG 88, it falsely reported that radiation is um, radiation is not adding radiation is not superior. So, as per the present recommendations, elective irradiation of groin nodes is not recommended outside a trial protocol and only in low risk cases with CT based treatment planning to completely cover the nodal bed. But the data is still evolving on this aspect. Next, please. Then neoadjuvant chemoradiation. Cisplatin or 5-FU alone or in combination along with or without mitomycin have been used along with radiation. The idea is to reduce the extent of surgery, and in this is an MD Anderson study, and nearly half the patients in this study showed response to neoadjuvant chemoradiation and had no visible vulvar disease at the time of planned surgery. Similar studies were also done by California University and Loma Linda University, and usually this approach is desirable for midline tumors where deep or radical excisions could compromise on the clitoral or sphincter's function, even if there is tumor regression. Then definitive chemoradiation. Now this is quite a debatable subject. There are no definite RCT based evidence on it, and most of the data is based on phase 2 series or retrospective series. So it is still debatable whether giving definitive chemoradiation can we can do away with surgery totally. There is encouraging evidence coming that you can allow organ preservation in and remove extensive surgery, and so far it has been indicated for elderly patients and those medically unfit for radical surgery. Long-term survival rates between 20 and 45% in advanced cases have been seen, and as I will be presenting one data with IMRT from MD Anderson Institute, it still cannot take the place of surgery and radiotherapy given together as bimodality treatment. So then coming to the next type of radiation is for recurrent disease. So even in recurrent disease, they can be a group of patients who will perform better, and these are those with smaller primary recurrence, the size of the groin recurrence being also small, 2 centimeter or less, lack of perineal skin involvement, lack of significant tissue necrosis, and those in which you can give higher radiation doses. Usually what has been seen is if adequate radiation and surgery has been done before, then recurrence in the inguinal nodes almost never gets salvaged, though perineal failures can be managed depending again on the size. Aggressive or non-aggressive treatment for such recurrent disease depends on patient status, performance status, as well as extent of disease involvement. Then coming to palliative radiotherapy for locally advanced, extremely advanced disease, metastatic disease, or those with significant comorbidities to palliate symptoms such as bleeding, ulceration, necrosis, pain, or discharge. And we have treatment regimes such as 25 to 30 gray in 10 fractions. So technique, when treating the vulva alone, an appositional perineal field is used with the patient in lithotomy position. The beam energy should cover the required depth. If the tumor cannot be adequately encompassed by a smaller field, an anterior posterior photon field is used with the patient in the frog leg position to minimize dose to the inner thighs. Bolus is used to ensure full dose to the mucosa and skin where indicated. In pre-op radiotherapy, the portals will include the groin, the perineum, and the low pelvic nodes. In the adjuvant setting, APPA fields usually include both the vulvar and nodal bed, It can be used in single portal or it can be used as matching portals. The CTV should include the entire operative bed, and in case of close or positive margins, at least 2 centimeter of tissue beyond the bed. If this results in significant perineal tissue being involved in the field, then you can put a central shield in the APPA fields and just treat the bilateral inguinal and the pelvic areas, and later on add a direct perineal field to treat the vulva. When electrons are used for perineal field, or if we are using electrons for the inguinal fields, then we should take care for the lateral divergence of these electron beams, especially in the medial part of the lateral electron fields and the lateral part of the medial electron fields. I'll just show the photos. So in this lower photo, you can see a wide AP and a narrow PA field. This when you are doing 2D planning. We will also show the portals for 3D planning. In the other photo, you can see a APPA central field matched with lateral inguinal electron fields, where we have to take care that the medial ballooning of the electron fields is properly matched with the lateral borders of the photon fields. So these are the two types of fields we use for vulvar cancers, and patients should be simulated and treated with consistent bladder and rectum filling if possible. So it should be a comfortable full bladder with the empty rectum. If the vagina is involved by disease and we intend to treat the vagina, the simulation should be performed with both a full and an empty bladder to measure the extent of vaginal movement antero-posteriorly to create an ITV for the vaginal area. Sorry. Organs at risk, we have the RTOG protocols for the dose constraints for the bowel, rectum, bladder, and the two femoral heads. And you can see the doses. Broadly, volume receiving 40 gray, less than 30% in bowel, rectum and bladder, again, volume receiving 45 gray, less than 60% in rectum and 35% in bladder. And volume receiving 30 gray, 40 gray and 44 gray to less than 50%, 35% and 5%. So when we are doing CT based planning, there will be various situations. I have just put forward the CTVs and then I have a photo also for that. So for the various CTVs for vulva, so if lesions are involving the vagina proximal to the hymenal rim, the CTV should include a 3 centimeter margin on the GTV. If there is uncertainty regarding the proximal extent of tumor or if there is lymphovascular invasion, the entire vaginal length should be included. If this is a post-dissection, nodal dissection, so the nodal CTV should include the surgical clips, the seroma, the femoral vessels with the margin, scar and subcutaneous tissues in between CTV for at least 2 centimeter along the urethra. Next. For vulvar lesions extending to the anus or anal canal, bladder or the rectum, the CTV margins should extend at least 2 centimeter into the anorectum or the bladder. For periurethral lesions, the CTV margins should extend at least 2 centimeter along the urethra, or if the disease extends to the mid or proximal urethra, then the entire urethra and bladder neck should be included. For periclitoral lesions, the CTV should include at least a 2 centimeter margin on the GTV. In many cases, if the suspensory, if there is involvement of the ligaments of the clitoris, then we have to extend the CTV up to the pubic bone. So these are the recommended doses. I'll just go to the next slide first and then come back to this slide. Could I go to the next slide first? Okay. or we'll continue with this slide. Uh, 1 second. I have a few. So these are the doses. Um, Adjuvant RT to the inguinofemoral nodes 45 to 50 gray, adjuvant RT to the perineum 45 to 50 gray. In case of T3, T4 lesions, doses beyond 60 gray, and as well as the same for lesions with extracapsular extension or positive margins. In case you are giving elective RT to the inguinofemoral nodes 45 to 50 gray, conventional doses. Definitive chemoradiation 60 to 64 gray, again in conventional doses. Preoperative chemoradiation 40 to 50 gray in fraction sizes of 180 to 200. And palliative 25 to 30 gray in 10 fractions. Next slide, please. So these are the I wanted to show. So these are the various CTVs. So the first two rows are the post-dissection nodal CTV, which includes all the surgical clips, the seroma cavity, the femoral vessels and margins along that. And then if there is periurethral disease, then you should extend at least 2 centimeter down along the urethra. So this is basically from Vishwanathan et al. And in case we are doing IMRT, then again we include the vulva, the vagina, proximal vagina, the groin nodes as well as the pelvic nodes. So various areas can be are shown as delineated. Now this is an interesting paper from MD Anderson on the use of IMRT in vulvar cancers, and the doses they gave were GTV dose post-op in the post-op setting and in the definitive setting. So in the post-op setting, when negative margins and no extracapsular extension was there, the GTV received 50 to 51 gray. Again, elective nodes the same. There was no nodal boost. Vulva positive margin 60 gray. Elective nodes 50 to 51 gray. No nodal boost. Nodes with extracapsular, again vulva GTV dose was 50 to 51 gray. Elective nodes same, and further nodal boost up to 60 gray. In case definitive radiation was done, then without brachy and with brachy. So without brachy 60 to 70 gray, elective nodes 50 to 51 gray with a nodal boost up to 66 gray. If brachy was there, then IMRT 60 gray, EVRT plus 12 gray brachytherapy. Nodal dose was 50 to 51 gray, and a nodal boost up was given up to 66 gray. Next. So this shows the results of treatment, and as you can see, the local regional control is better for early stage disease as well as for tumor size less than 3 centimeter. What is more important are the two plots below. If you can see the overall survival as well as the local regional control for definitive RT, adjuvant and neoadjuvant. For adjuvant RT versus definitive RT, you can see that the local regional control for adjuvant is superior to definitive RT. And overall survival, the difference is, however, not very significant. So definitely to addition of surgery along with radiation does give a better local regional control. Next slide. This table shows the same, the figures what we saw in the previous slide. Addition of adjuvant or addition of surgery to or addition of radiation to surgery, I would say it's the other way around, would improve the local regional control. However, the morbidities with both modalities work out to a similar overall survival in the long term. Coming to brachytherapy, next slide. Interstitial implant brachytherapy is a treatment option for either locally advanced disease or even for very early disease in patients who are medically inoperable or in recurrent vulvar disease. It is especially useful in lesions near the urethra or the clitoris, where surgery would result in loss of organ function. Potential morbidities include fistula formation and ulceration. Usually it is done with the help of CT planning. This was one case where the disease, it was a recurrent vulvar lesion with the disease limited to around the clitoris. There was no extension of the disease into the vagina or into the urethra or inside the labia. So next slide. These are schematic. Next slide, please. Yeah, these are schematic photos I have made for both free flexible needle implant as well as a template based implant. So we in the previous slide the disease was about 1.5 into 1.5 into around 1 centimeter. So with taking adequate margins, the area of implant would be a box of 3 into 3 into 2 centimeter, and in a perineal implant, using a perineal template based implant, we could put in needles in 3 planes to a depth of around 3 centimeter. Similarly, flexible, if in certain cases we can, if the disease is very superficial, we can use the flexible implant also. And as you can see, if the depth is say 1 to 2 centimeter, then single plane or double plane catheters could be inserted into the vulvar tissue. So even a flexible implant is possible, and doses can range from 12 to even a full brachy dose given like 35 to 40 gray in 10 to 12 fractions. So this would be equivalent to a dose of near 60 gray. Next, please. So once a treatment is over, follow-up examination again should include history and physical examination, pelvic examination, and a chest X-ray annually. Imaging studies should be done as per indicated on physical examination, lab studies, or the history. So the interval between follow-ups should be every 3 months for the first 2 years, every 6 months for years 3 and 5, and over after 5 years an annual examination. Next, please. So if I would like to sum up a vulval disease, in early stage disease, surgery is considered complete therapy. Role of this is as per the Royal College of Obstetrics and Gynecology recommendation. I have broadly divided the recommendations into RCOG and FIGO. So early stage disease, surgery is considered complete treatment. Role of lymph node dissection is debatable. Sentinel node dissection considered adequate to decide on further nodal dissection. Again, as per FIGO, surgery is the primary modality, and along with sentinel node dissection. In case of stage 3 disease with groin nodes, surgery is the cornerstone of therapy as per RCOG. This is a category A recommendation, and in FIGO also level 1, that surgery is the primary modality. Nodal dissection can be limited to inguinofemoral dissection. Pelvic lymphadenectomy may not be done. It can be associated with increased morbidity. Then adjuvant artery to inguinofemoral nodes, the FIGO says that there is substantial clinical benefit. Level 1 evidence is there for adding adjuvant radiation, especially for patients with 2 or more nodes or ECE. Adjuvant artery to perineum, recommendations include close positive margins, more than 5 mm stromal invasion, LVSI, or infiltrative growth. Next. Elective artery to the inguinofemoral nodes. FIGO says that it is not yet recommended outside a trial protocol based on the adverse reports of GOG 88. and if it is done, it should be done with CT based planning. Definitive CCRT, RCOG says individual women who cannot receive surgery should be treated with primary radiation. FIGO says there are single institution series with high response rates. A role vis-a-vis pre-op chemo-RT is still debatable. Not fit for surgery should be considered for radical RT level 2B evidence. In recurrent disease, again, those not responsive to chemotherapy or variable response can be taken up for either surgery or radiation. Again, they have given various indications in the FIGO. And finally, palliative RT, as I've explained before, various indications have been given for palliative RT. So that's all about vulval cancers. Now we go to cancers of the vagina. This is even shorter topic. They represent less than 2% of the malignant neoplasms of the female genital tract, and more than 80% of the cancers involving vagina are usually those that have come in from cervix or endometrium, colon, rectum, ovary, or vulva. So de novo primary cancers of the vagina represent less than 2%. More than 50% of patients are diagnosed in the 7th or later decades. Mean age is 67. And as you can see, squamous cell is the most common at more than 80%. Next. Over 90% of the intraepithelial lesions as well as 70% of vaginal cancers are associated with HPV infections, and 16 and 18 HPV variant 16 and 18 are associated with more than 60% of these. However, prophylactic HPV vaccination, the rule is still not defined. Prior pelvic radiation, chronic local irritative conditions, as well as maternal exposure to DES or fetal exposure to maternal DES have been thought to be other risk factors for development of these cancers. Next. Yeah, most lesions of vaginal cancer occur in the upper vagina. Cervical should be excluded. Examination of the perianal area is done to rule out a synchronous anal cancer. And if the disease is still not visualized in presence of abnormal cytologic results, then colposcopy of the cervix and vagina should be done. Imaging studies indicated are chest X-ray, CT or MR of the abdomen and pelvis, and a PET scan. Lab tests include complete blood count, LFT, RFT, and an HIV test. Next, FIGO staging. Stage 1 is limited to the vaginal wall. Stage 2 is where subvaginal tissue has been involved, but not the vagina extended to the pelvic wall. Stage 3, where extended has Yeah, am I audible now?
Yes, you are audible. Please.
Yeah, so I'm sorry, there was this fluctuation in the net, I got disconnected.
Yeah.
So could we go on to the next slide? Did was the staging audible?
No, actually, from this slide you are not audible.
Okay. So I'll go back to that slide. So stage 1 is disease limited to the vaginal wall. Stage 2 is involvement of the subvaginal tissue, but not extending to the pelvic wall. Stage 3 is involved the pelvic wall. Stage 4 is involvement of the bladder or rectum mucosa, as well as bullous edema of the pelvic area. So nodal is no regional, and N1 is pelvic or inguinal node metastasis. M0 N1 is no mets or distant mets. So going to the treatment options. First, a variety of treatment options for intraepithelial neoplasms, such as excision, use of topical 5-FU chemo, or CO2 ablation. Recurrence rates after the first treatment ranging from 0 to 60%. Brachy has also been used in intraepithelial neoplasms with equidative doses of 70 to 80 grade 2. Radiation therapy is the treatment of choice for most patients with invasive squamous cell carcinoma. And finally, you have the melanomas, which either need, if operable, need to be operated, or they can be treated with hypofractionated radiation. Surgery in squamous cell carcinoma has a limited role. So, stage 1 surgery is mainly limited to disease involving the upper posterior vagina, and in patients with intact uterus, upper vaginectomy with 1 centimeter margins and pelvic lymphadenectomy can be done. This is according to FIGO 2006, a grade C level option. In patients with the prior hysterectomy, radical upper vaginectomy with the pelvic lymphadenectomy is an option. In stage 4A disease, especially if there is a rectovaginal or vesicovaginal fistula, then pelvic exenteration with lymphadenectomy or pre-op RT can be done. If lower third of the vagina is involvement, then bilateral groin dissection should be considered. And if in patients who have had a central recurrence after radiation, pelvic exenteration would be a necessity. So, and we have about radiation, we have MD Anderson data, which is the largest for this group of patients. Nearly 30 years of data with about 193 patients, and at 5 years, the disease-specific survival rates were 85% for nearly 50 patients with stage 1, 78% of 97 patients with stage 2 disease survived at 5 years, and 58% with for 46 patients with stage 3 to 4A disease survived at 5 years. So the algorithm for treatment radiation in vaginal tumors, stage 1 versus stage 2, and then stage 3 and 4A. Stage 1, in a small volume disease, we have small volume external beam along with either posterior vaginal boost or brachytherapy. If brachytherapy is not feasible, then give posterior vaginal boost. If feasible, then interstitial or intracavitary boost. Stage 2, large treatment volume if the parametrium is involved, otherwise small volume external beam, along with concurrent cisplatin chemotherapy for disease size more than 4 centimeter. Again, if posterior vaginal boost is possible, then with the 3D CRT you give posterior vaginal boost. Otherwise, you do interstitial brachy or intracavitary brachy. Then for stage 3 and 4A, you have a large treatment volume external beam radiotherapy with concurrent chemo, followed by 3D CRT posterior vaginal boost, and after completing radiation, if there is good response or complete response, you follow up the patient. So, according to the location and size, MD Anderson again had come out with guidelines for vaginal radiotherapy. EBRT up to 40 to 50 gray first for first apical and distal regions. They're divided. For apex tumors, less than small volume disease, less than 0.5 centimeter, 40 to 50 gray of EBRT followed by ICRT, 50 gray and for vaginal surface dose. So, and for disease size more than 0.5, EBRT further boost or interstitial template brachytherapy. In case mid vagina, for anterior or lateral vagina, interstitial freehand template for a dose of 25 to 30 gray. Posterior or large volume disease, external beam boost. In distal vagina, for confined disease, again, sorry, interstitial brachytherapy 25 to 30 gray, or in large volume disease, external beam boost. So what would be the fields for small volume? In this, the light blue colored strips are the is a area taken along the common iliac and the external and internal iliac, while the darker blue is the purple colored strips down below are the femoral vessels, and the blue cylinder below in the field, middle of the field, is the vagina. It has been marked out. So these are the areas marked out, and these are the small volume fields, the AP and the lateral. Whereas if you want to take the larger field for more extensive disease, I have put it in the next figure. So for stages 1 to 2A, you have a small treatment volume, 4-field technique with the superior edge of the, sorry, it is a small mistake. The superior edge of the field is put at the bottom of the SI joint. The superior edge of the field is put at the bottom of the SI joint. For the larger treatment 4 field, you have, as you can see in the figure above, it goes to the L5S1. So in the small treatment volume, you go to the bottom of the SI joint, and for the large treatment volume, you cover the L5S1. So this is the difference. The lateral edge goes to around 1.5 to 2 centimeter beyond the marking of the vessels, and the lower edge of the field is below the obturator foramen. And you have shrinking field techniques with 3D CRT to escalate dose if brachytherapy is not feasible. And for posterior vaginal tumors, an EBRT boost is recommended to minimize the risk of rectal complications. One second. Yeah, this one. Next slide. Yeah. So as I said, margins of 1.5 to 2 centimeter from the vessel markings to the field edge. For the lateral edge, we use the CT simulation with the vessel contouring done as a surrogate for the lymph node localization, rather than just putting a bone-based field markings. The open or frog-leg position is useful when treating the inguinal area to minimize skin reactions from the skin fold, and a small radioapex marker seed is inserted into the distal portion of the tumor for the distal edge of the field, or the lower edge of the field. Selective radiation of the inguinal nodes is recommended for tumors involving the lower third of the vagina, and with this practice, the rates of inguinal failure are less than 1%. If inguinal lymph nodes are involved, we use a modified segmental boost technique to reduce those inhomogeneity. If I can go to the next slide first, I'll just show the segmental boost technique. Could I go to the next slide first? Yeah. So the segmental boost technique, basically, I need a large anterior and a restricted posterior field. So so in the as you can see, the anterior fields, the lateral portion in the second, this one, the anterior oblique, where it is written anterior oblique. So those are the segmental boost areas for the anterior, the part of the anterior field which is projecting beyond the posterior field. As you can compare, the anterior field is bigger than the posterior field, and it is in the lower lateral corners of the posterior field where you have the extra boost areas. So this is the segmental boost zone we try to treat. Now, could I go back to the previous slide? Yeah. So the doses generally are for pelvis, the EBRT dose is 40 to 50 gray. Primary boost, either intracavitary low dose vaginal surface dose is at 5 mm. Deep is 50 gray for apical lesion. If we are doing interstitial, then at LDR 25 to 30 gray. If we are using 3D-CRT vaginal boost, then a total dose of 60 to 70 gray. For parametrial involvement, you can additionally add boost up to 65. For pelvic sidewall involvement also, go up to 60. If there are inguinal nodes medially, then elective dose up to 45 to 50 gray, or for involved inguinal nodes be up to 60 gray. So that's about vagina. So, thank you. I'll be happy to take questions.
Thank you so much, sir, for this nice class. Am I audible?
Yeah.
So let us see if there are questions in the chat box. The first question is, will 60 gray suffice for gross disease?
So 60 gray for which one? Which one was asked?
I think the
vulva or vagina?
It was regarding the vulva.
So 60 gray will definitely not suffice for vulva, and as you saw when I presented the data also, for if you are going ahead with a definitive chemoradiation, I will go ahead for say 40 to 50 gray for the elective field, and just 1 minute, I'm opening the dose chart again. So I'll go for 40 to 50 gray to the elective. For definitive chemoradiation, I have gone to 60 to 64 gray in conventional fractions. So it is beyond 60 gray. 60 gray, I had been insisting on 60 gray for adjuvant RT to the perineum in cases of T3, T4 lesion or extra capsule extension or positive margin.
The next question is, should mons pubis be included in the field?
Mons pubis should be included, as I said, if there is extension into the urethra.
Okay, thank you, sir.
So if the ligaments are involved, then you extend those up to the pubic bone. So mons pubis, if the soft tissue, if you are talking, I would not really include.
So if there is a clitoral involvement, will you include the mons pubis?
If it is coming within 1.5 centimeter, again, what is the size of the primary? Is it a small localized disease? Is it a small localized disease in the de novo setting, in the recurrent setting, or is it a locally advanced disease involving the clitoris with extension to the urethra? So these are the 3 conditions or 4 conditions I can make out. So if it is a de novo small disease, I could just do a limited surgery with a sentinel node dissection, and that's the end of it. I need not irradiate the mons pubis at all. If I want to preserve the function, I might do a brachytherapy for a very superficial or small disease, or I can do conformal radiotherapy. In conformal radiotherapy, if it's an early stage disease with no nodes, then I don't need to go up to the mons pubis. If it is a recurrent disease also, my margin would be 1 to 1.5 centimeter. So again, it depends on what is the bulk of the disease. If it's a very small, as I showed a figure, it was 1.5 into 1.5. So there I don't need to go. But if it is 3-4 centimeter size big disease, then I might need to go.
Thank you, sir. The next question is, in vulval cancer, when do you consider elective nodal irradiation, elective inguinal nodal irradiation?
Vulvar cancer.
Yes.
Isn't it? So
Yes.
anything more than stage 2 beyond. Stage 2 beyond. Now stage 2 beyond, we have as per GOG, again, if you are saying just nodal irradiation and no surgery, there is really no evidence. See, the evidence for the GOG 37 is an adjuvant RT to the perineum or adjuvant RT to the inguinofemoral nodes. Whereas elective RT, there is evidence coming up that it is superior, but GOG 88 spectacularly failed. And they used a wrong protocol. So until we have further evidence, definitely pre-op chemoradiation is superior or definitive chemoradiation is equivalent to adjuvant. If I were to use it as a standard protocol, it would be difficult to say.
Thank you, sir. Dr. Hina wanted you to explain the segmental field technique once again.
Okay. See, segmental, basically in vagina, what we are doing is lower vaginal involvement. We have to consider the inguinal boost areas. So it is similar to, yeah. So could you go one slide? 1 minute. I'll also come down. Yeah. So if you see, the anterior field is bigger and the posterior field is smaller. So the lateral edge of this and posterior or the latero-inferior edge of this anterior field, that is given as a separate boost rather than involving a lot of normal tissue in taking a big anterior field and a smaller posterior field. So it is something similar to what I said in vulva about 2 equal APPA fields with electron matched electron inguinal node fields. Here match the photon fields to the anterior field. So you distribute it as 2 segments. Is it still not?
So if I understand it correctly, it's like superimposing the 2 fields and the deficiency at the lower inferior corner.
Yeah.
That is the area which we have to boost from the anterior field, because we don't want to give too much of dose posteriorly because the nodes are placed anteriorly.
Yes.
Thank you, sir.
So you have put it in better English than me.
In fact, sir, I think anyone who did all this 2D planning in their life, they will never forget this. Sir, in cervix we go up to 85 gray. So can we give such high dose in vulva? The next question.
See, what is the tolerance value of the vagina and the vulva? So the tolerance of the upper 2/3 vagina is up to nearly 150 gray, 100 to 150 gray, while the lower vagina, the tolerance comes down to 60 to 70 gray, and the tolerance of the vulva is about the same. So we can't go up to 85-90 gray in cervix, like in cervix. So uterus, you should classically remember what are the tolerances. See, cervix, you are not giving 85 gray to the, you are prescribing around 80 to 85 gray to the point A, which is which is the least, the weakest link in the chain in the entire area. So the uterine corpus and the uterine cervix, the central axis, that dose is actually more than 100 plus. So the tolerance of the uterus goes up to even 200 gray. the tolerance of the lower uterine segment comes down to between 150 to 200. Of the vagina, upper vagina 100 to 150, and lower vagina is 65 to 70. Similarly, vulva comes down around 65 to 70.
Thank you, sir. Any role of SLNB in stage 2 of vulval cancer?
See, sentinel node is mainly done in early tumors, not in locally. Though, as per the recommendation, early stage is classified as non-bulky stage 2 and stage 1. So, any disease less than 3 centimeter in size, sentinel node would be sufficient for that. Beyond 3 to 4 centimeter size primary, it is better to go ahead with if you can go back to a few some of my early slides. If I had said that there is a correlation of size with the, I think it is in the first 20 slides. Slide number 17. Yeah. So less than 2 centimeter. If you go to slide number 17, 17. Yeah. So if you go to see this, so 2 centimeter, less than 2 centimeter tumor is around 19% positive node. 2 to 3 centimeter is between 20 to 40%, but beyond 3 centimeter, it goes up to 70%. So sentinel node, usually we prefer for lesions below 3 centimeter. Beyond 3 centimeter, it would not be suitable.
Thank you so much, sir. And the last question, can you please explain planning for vaginal cancer once again?
Okay, I think that was I also lost steam by that time, maybe a little out of energy by that time. So I'll go back to radiotherapy planning. So slide number 66. Yeah. So for stage 1, stage 2, and then stage 3 onwards. So stage 1 is a small volume disease. We treat the initial small volume vagina along with nodes to a dose of 45 to 50 gray. After that, depending on whether brachytherapy is available or possible, we give intracavitary brachytherapy. If it is not possible, then we give posterior vaginal boost to a total dose of 60 to 70 gray, total dose. Whereas if we give brachy, then for stage 1, a vaginal surface dose of 50 gray, or if it is stage 2, then up to 25 to 30 gray boost. Then in stage 2, again, depending if it is a large volume tumor, stage 2 bulky, or stage 2 small. Is stage 2 bulky, then large volume EBRT, that is the upper border of the field, is at L5S1. If it is a small volume disease, then it is at the lower border of SI joint, that is at the beginning of true pelvis. Basically, the upper border of the pelvic field is at the beginning of true pelvis. The lateral borders are 2 centimeter beyond the marked out blood vessels. See, my difference here from a conventional bony landmark based is we assume that the field borders of the vessels go along the lateral edge of the true pelvis, but sometimes they might differ. So what the present recommendation is mark out the vessels. Your lateral borders are 2 centimeter beyond the 2 centimeter beyond the marked out vessels, and the lower border is at the lower border of the obturator foramen. The vagina has been marked out as a cylinder in the middle of the field, so that will be boosted later. And as you can see, the small volume field, the upper border has ended at the SI joint, which is the beginning of the true pelvis, and the large volume field, the upper border starts at the L5S1. So this is the difference between the two. Then coming down, according to MD Anderson, again the same thing. They divided the vagina into apical, mid vagina, and distal vagina. In apical vagina, again small volume or larger volume. Small volume less than 0.5, larger volume more than 0.5. So after 40 to 50 gray, the less than 0.5 centimeter ICBT, 50 gray vaginal surface.
I'm just interrupting you, sir. In this, this 0.5 means, is it a craniocaudal, lateral, or the thickness?
The thickness of the disease. We cannot I mean, they have measured it as the thickness of the disease. Because only if it is less than 0.5, then they can treat by surface toe, I think by cylinder or a central tandem.
Right, sir.
So if it is more than 0.5, then it is again a EBRT boost or a interstitial template. So in mid vagina, again anterior or lateral, we give a template based brachy 25 to 30 gray, or posterior or a large volume disease, then posterior vaginal boost by 3D-CRT.
Sir, will you please explain one pertinent thing in this regard, that in mid vagina and distal vagina, intracavitary radiation is not recommended? What is the reason? The straightforward way mentions interstitial.
Yeah, because in mid vagina, see, what is the intracavitary portion you can give? Your typical ovoids the dose comes down to another 2 centimeter below the typical. And don't take the cervical field. If you take even the ovoid, that simple tandem and ovoid distribution that we use for cervix, how much of the vagina does it treat? It usually treats upper half to upper 2/3 of the vagina. Okay. So that zone is a transition zone. Whereas if I am using a cylinder, the cylinder is going to treat 0.5 centimeter beyond the surface of the cylinder. So again, I won't be sure of the dose distribution.
Thank you, sir. Thank you so much.
So if it is a larger volume disease in the mid vagina, then interstitial template, using a perineal template, we can just put a central tandem and we can put the first layer of needles either anteriorly or along the sides as a single plane, and we can get the dose distribution. Okay.
Thank you so much, sir. Yes.
Yeah, and for the posterior portion, they are still preferring an EBRT boost to, obviously, they don't want a needle insertion into the rectum. Now, again, for distal vagina, which is near the vulva,
don't you believe that if a layer of needles can be placed properly within the rectovaginal septum without actually piercing the rectal mucosa?
I said MD Anderson guidelines. I'm not saying this is my guideline.
So I'm just asking.
So we can. It would depend on personal expertise. It would depend on personal expertise, because in cervix also, or where the anatomy in recurrent diseases, there are indications of using the needle template and putting a needle in the rectovaginal septum also.
Right, sir. Thank you. Thank you, sir.
So it depends on personal expertise. So this particular indication was taken from a book by Dr. Akila Vishwanathan, and she has given these guidelines as per, I think, her institutional protocol.
Right, sir.
So then for the distal vagina, again, we are confined. For the confined disease, small volume disease, you can simply, after EBRT of 40 to 50 gray, you can give interstitial template brachy, or for a large volume disease, you have to boost it up to 70 gray. Okay.
Thank you so much, sir. And I think with this we have completed the entire class, including all the questions. So it was nice listening to your beautiful presentation, sir, and a lot of information, very comprehensive, and explaining all the techniques and everything into detail. And thank you once again for being with us on a Sunday morning.
Thank you.
Thank you all.
Pleasure's all mine.
Thank you, sir. Thank you so much.
Thank you.
Good day and good day to everyone.